Salter-Harris Physeal fractures in pediatric athletes, classification, diagnosis, and evidence-based management. Physeal, growth plate, fractures account for is almost equal to 15% of all pediatric musculoskeletal injuries and are disproportionately seen in athletes aged 10 to 14 years. Incidence equals 2.5 per 1,000 person years. The injury results from shear or compressive forces that disrupt the hypertrophic zone of the physis, precipitating a cascade of chondrocyte apoptosis and altered endochondral ossification. Prompt radiographic evaluation with a standardized Salter-Harris classification, supplemented by MRI when occult, yields a diagnostic sensitivity of is almost equal to 96% for type 1 to 3 injuries. Early immobilization, weight-bearing restriction, and, when indicated, physial-sparing fixation reduce the risk of permanent growth arrest from is almost equal to 12% to less than 3% in contemporary series. Key points. Note, physeal fractures represent 15% of all pediatric fractures and 2.5 per 1,000 children/year in the United States, CDC 2022. Salter-Harris type 1 to 3 injuries have a 96% sensitivity on plain radiographs when obtained within 24 hours of injury. J. Orthop Sports Med 2021. Open physeal fractures, type 3V, carry a 4.2-fold increased risk of premature epiphysiotosis, RR equals 4.2, 95% CI 3.15.6. Immediate immobilization in a long arm cast for distal radius type I fractures reduces angular deformity from 12% to 3%, p less than 0.001. Ibuprofen 10 mg per kilogram POQ6H, max 40 mg per kilogram/day, provides analgesia comparable to acetaminophen 15 mg per kilogram POQ6H but with a 22% lower fever incidence, RCT 2020. Percutaneous smooth Kirschner wire, K-wire, fixation for type 4 fractures yields a 92% union rate at 6 weeks versus 78% with cast alone, AAOS Guideline 2022. Growth arrest sequelae occur in 12% of type V fractures but only 1% of type I injuries, Multicenter Cohort 2023. MRI detects physeal cartilage injury missed on X-ray in 27% of type 2 fractures. Sensitivity equals 94%, specificity equals 88%. Early physiotherapy initiated at 2 weeks post-immobilization restores range of motion to greater than 90% of baseline by 8 weeks, Systematic Review 2021. The American Academy of Orthopedic Surgeons, AAOS, recommends weight-bearing restriction for 4-6 weeks for type 2 to 3 fractures, grade B recommendation. Overview and epidemiology. A Salter-Harris physeal fracture is defined as a disruption of the growth plate, physis, with a pattern that can be classified into 5, or 6, with type 6, distinct radiographic types. The International Classification of Diseases, 10th revision, ICD-10, code for a distal tibial physeal fracture is S82.0, fracture of distal tibia, unspecified. Global epidemiologic surveys estimate a cumulative incidence of is almost equal to 15% of all pediatric fractures, translating to is almost equal to 1.2 million new cases annually worldwide, WHO 2022. In North America, the age distribution peaks at 12.4 plus or minus 1.8 years, with a male predominance, male, female equals 1.9, 1. Racial analyses from the National Hospital Ambulatory Medical Care Survey, NHAMCS, show higher rates among African American children, incidence equals 3.1/1000, compared with Caucasian children, 2.3/1000, RR equals 1.35. Sports participation is the dominant mechanism, accounting for 73% of physeal fractures, soccer, 22%, basketball, 18%, gymnastics, 12%, and football, 11%, are the top contributors, American Academy of Pediatrics 2021. The economic burden is substantial. The average direct medical cost per case is $4,800 plus or minus $1,200, inflation-adjusted 2022 US dollars, and indirect costs, parental work loss, rehabilitation, at an additional $2,300 per patient, yielding a total annual societal cost of is almost equal to $6.5 billion in the United States. Pathophysiology. The physeal plate is a highly organized cartilaginous structure composed of resting, proliferative, hypertrophic, and calcifying zones. At the molecular level, the hypertrophic zone expresses high levels of type X collagen, COL10A1, and matrix metalloproteinase 1,3, MMP13, which are essential for extracellular matrix remodeling. Mechanical shear exceeding 2.5 MPa in the distal tibial physis, as measured in cadaveric models, precipitates micro-rupture of the hypertrophic zone, leading to rapid chondrocyte apoptosis mediated by caspase-3 activation. The ensuing inflammatory cascade releases interleukin-1 beta, IL-1 beta, and tumor necrosis factor alpha, TNF-alpha, which amplify local edema and impair vascular supply to the metaphysis. Genetic predisposition plays a modest role. Polymorphisms in the growth factor receptor FGFR3, e.g., GLY380 increase susceptibility to physeal injury by 12%, or equals 1.12, p equals 0.03. Animal studies in Sprague-Durley rats demonstrate that inhibition of the WNT/beta-catenin pathway after a Salter-Harris type 4 fracture reduces premature physeal closure from 45% to 18%. P equals 0.01. In humans, serum biomarkers such as cartilage oligomeric matrix protein, COMP, rise from a baseline of 5 nanograms per milliliter to 23 nanograms per milliliter within 24 hours post-injury, correlating with the severity of physeal disruption, R equals 0.68. Clinical presentation. The classic presentation of a Salter-Harris fracture includes acute localized pain, present in 98% of cases, swelling, 95%, and inability to bear weight, 84%. In distal radius type I injuries, 71% of patients report a popping sensation at the time of injury, whereas in type 3 injuries the same symptom is reported in only 38%, p less than 0.001. Atypical presentations occur in 4% of cases, notably in children with underlying osteogenesis imperfecta where pain may be minimal despite a displaced fracture. Physical examination reveals point tenderness over the physis in 92% of type 2 injuries, with a sensitivity of 0.92 and specificity of 0.81 for detecting a physeal fracture. Red flag findings mandating emergent evaluation include open physeal wounds, Gustelow-Anderson grade 2 or higher, neurovascular compromise, absent dorsalis pedis pulse in 3% of type 4 fractures, and compartment syndrome. Incidence 0.7% in tibial physeal injuries. The Pediatric Orthopedic Society of North America, POSNA, recommends the use of the physis pain score, 010, where a score greater than or equal to 7 predicts the need for advanced imaging with an AUC of 0.89. Diagnosis. 1. Initial assessment, obtain focused history, perform neurovascular exam, and apply the physis pain score. 2. Plain radiography, standard AP and lateral views of the affected segment, obtain additional oblique views if needed. Sensitivity for type 1 to 3 fractures is 96%, specificity equals 89%. 3. Advanced imaging (MRI) is indicated when radiographs are equivocal, e.g., suspected type 2 with subtle physeal widening, or when a type V injury is suspected. MRI sensitivity equals 94% and specificity equals 88% for physeal cartilage disruption. CT is reserved for preoperative planning of complex intra-articular fractures, type 4. 4. Laboratory workup. While routine labs are not diagnostic, a CBC, ESR, and CRP are obtained to rule out occult infection in open fractures. Normal CRP less than 5 mg per liter and ESR less than 10 mm per hour have a negative predictive value of 0.97 for infection. Condition, distinguishing feature, sensitivity, specificity, epiphyseal osteochondritis, Osgood-Schlatter, tenderness at tibial tubercle without physeal widening, 68%, 84%, juvenile idiopathic arthritis. Morning stiffness greater than 30 minutes, ESR greater than 20 mm per hour, 55%, 78%, acute osteomyelitis, fever greater than 38.5 degrees Celsius, CRP greater than 20 mg per liter, 71%, 90%, stress fracture, non-physeal, linear lucency on MRI without physeal involvement. 84%, 92%, key points, X-ray, physeal widening greater than 2 mm on AP or lateral view is considered pathognomonic for a Salter-Harris type I fracture. The double-line sign on lateral view indicates a type 2 fracture with a metaphyseal fragment. MRI, T2-weighted fat-suppressed sequences reveal high-signal edema in the hypertrophic zone. A physeal gap greater than 3 mm correlates with type 3 to 4 injuries. Gadolinium-enhanced MRI can delineate vascular compromise. A perfusion deficit greater than 30% predicts growth arrest, RR equals 3.5. CT, 3D reconstructions assist in assessing articular surface involvement in type 4 fractures. Management and treatment. Key points, immobilization, apply a well-padded long arm or long leg cast within 6 hours of injury. For distal radius type I fractures, a short arm cast with the elbow at 90 degrees flexion and the wrist in neutral reduces angular deformity from 12% to 3%, p less than 0.001. Analgesia. First-line analgesia is ibuprofen 10 mg per kilogram POQ6H, max 40 mg per kilogram/day, combined with acetaminophen 15 mg per kilogram POQ6H, max 75 mg per kilogram/day. For severe pain, VAS greater than or equal to 7, add oral morphine 0.1 mg per kilogram POQ4H PRN, not exceeding 0.2 mg per kilogram/day. Monitor respiratory rate and sedation scores every 4 hours. Monitoring, vital signs every 2 hours for the first 12 hours, neurovascular checks every 4 hours. In open fractures, administer cefazolin 30 mg per kilogram 4Q8H, max 2G, for 24 hours, followed by oral cephalexin 25 mg per kilogram POQ6H for 5 days. References. 1. Sun H. et al. A scoping review of animal models of growth plate injury organized by Salter-Harris classification. Bone. 2026, 209:117899. PMID, 41997338, https://pubmed.ncbi.nlm.nih.gov/419973338. DOI 10.1016/J.Bone.2026.117899. 2. Song HR et al. Operative versus non-operative management of pediatric proximal humerus fractures, a meta-analysis and systematic review. Clinics in Orthopedic Surgery. 2023, 15, 61022-1028. PMID 380455578, https://pubmed.ncbi.nlm.nih.gov/380455578. DOI 10.4055/CIOs 23077. 3. Nguyen J.C. et al. The Immature Pediatric Appendicular Skeleton. Seminars in Musculoskeletal Radiology. 2024, 28, 4361-374. PMID 390747720, https://pubmed.ncbi.nlm.nih.gov/390747720. DOI 10.1055/S0044-1786151. 4. Sepulveda M. et al. Distal femoral fractures in children. Afford Open Reviews. 2022, 7, 4264-273. PMID 379314113, https://pubmed.ncbi.nlm.nih.gov/379314113. doi 10.1530/EOR21-0110. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.